Hello guys, today we are going to start with the most popular disease which is diabetes mellitus, and in diabetes mellitus we have several types which we will see in the management of the complications of the diabetes. And now we will see the major parts that are type 1 and type 2 and type 2. In type 1, exhaustion of beta cells of pancreas takes place and which leads to insulinopenia. And in type 2 we have exhaustion of receptors of the insulin, or resistance to the insulin takes place. And in type 2, first we have increase in insulin, and in later on, as beta cell destruction takes place due to hyperglycemia, uh, burnout of beta cells occurs, and then destroying of beta cells leads to insulinopenia later on. Okay, now we will see the causes and classical symptoms, treatment, diagnosis, everything. And in the management of complications, we will study all the types in brief. Okay, so first of all we have classical symptoms. Classical symptoms are, first we have polydipsia, means more than 6 liter of water intake per day, and in ml 2 ml per liter, 2 ml per kg of body weight and per hour intake of water. And in the next comes a polyuria, more than 3 liter of urine output per day. And then comes polyphagia, and then comes weight loss. Sometimes question arises in examinations that what is not the classical symptoms of diabetes, and we have options, these four, that polydipsia, polyuria and polyphagia and weight loss. Then we will answer and tick this option, polyphagia, as this condition is not measurable. Okay, now we will go forward and see the diagnosis of diabetes. We have in symptomatic case these classical symptoms which we studied, and resting blood sugar more than or equal to 200 mg percent. In case of asymptomatic, we have fasting blood sugar is more than or equal to 126 mg percent, and after giving 75 gram of glucose, we check it after 2 hours, 2-hour value, that if more than 200 mg percent, then the patient have diabetes. And next method is, that is glycosylated hemoglobin test, HbA1c, because on the first carbon of glucose hemoglobin binded in the blood, that's why we say HbA1c. And uh, it normally present less than or equal to 5.6%, but in diabetics case value increases, that can be more than 5.6% to 6.4 or more than 7. In the case of a diabetic patient, we have to control glycosylated uh, hemoglobin. That is the best control, is that less we have to maintain the value of HbA1c is less than 7%. That is the best control of diabetes. And this test, HbA1c, is the best test for diabetes diagnosis because it is a retrospective test. Means it gives us older values of glucose also. How? It gives us average blood sugar level for 3 months. Okay, and it can't be affected by fasting. Like if someone comes is fasting, obviously he has no sugar hypoglycemia. And if patient come or person come with exercise, it also have he also have hypoglycemia. So this is the best test because it can't be affected by fasting or exercise. How it can give us value of average blood sugar? We calculate it, example, we calculate it by multiplying 25 with the HbA1c percent. Example, that someone comes, he had HbA1c that is 10%, so we will multiply it by 25, then we will get the average blood sugar for 3 months. Okay, that is 250 mg percent. And one more test we have, that is S-fructosamine test. S-fructosamine test, which is also a retrospective test, as it gives us value of average blood sugar for 2 to 4 or 7 weeks, but it is a short-term value, so it is short-term test. So we take best test is glycosylated hemoglobin test. Okay. Now we will see further, that is complications of diabetes. Okay, complications are divided into microvascular and macrovascular. Microvascular complications, that includes retinopathy, that is also divided into two groups, which are proliferative and non-proliferative. Then we have neuropathy, then we have nephropathy, and we will see these complications in brief next time. Okay, now we will take just overview of these complications. That in retinopathy we have problem with, we have blindness in the patient. Why? In the proliferative case, we have it due to neovascularization, leads to retinal detachment, and if retinal detachment takes place means the receptors of the eye detached, so uh, signals can't go in the brain, so blindness takes place. And in the non-proliferative case, we have aneurysms in the blood vessels of the eye or many more, so leads to blindness in the case of retinopathy. And in neuropathy, uh, silent MI takes place, that is silent myocardial infarction. And then we have sensitivity loss. It may be from skin. And in the autonomic sensitivity loss, we have silent MI. And in the motor sensitivity loss, we have no sensation for pain, etc. Okay. And in the nephropathy, we have chronic kidney disease that was seen in the two BJP leaders of India. Uh, First was who died, that is the finance minister Arun Jaitley, and second one is Sushma Swaraj, who is Minister of External and Internal Affairs of India. Next, we will see macrovascular complications. Macrovascular complications that includes CAD and PAD. CAD means coronary artery disease and PAD means peripheral artery disease. Okay, coronary artery disease, and which leads to further MI, fringe metal angina, unstable angina, etc. And it increase this diabetes increase the risk more than 3 times for chronic coronary artery disease. And in the peripheral arterial disease, we have complications that are gangrene or strokes due to atherosclerosis, uh, strokes that are maybe brain stroke, maybe any other cardiac stroke, etc. Okay, next we will see these complication in next videos. Okay, now we will see the management of diabetes. Okay, how we management, as I already said, that it depends upon type of diabetes. First, type 1 diabetes we will see. In type 1, we have exhaustion of beta cells of pancreas. This is our beta cell of pancreas. And we have GLUT2 receptor on the beta cell of pancreas, which is responsible for monitoring blood glucose level. And in the beta cells, we have pre-insulin or proinsulin, which are the immature form. And insulin is released from the beta cells if glucose level is more in the blood, and insulin is released with C peptide in 1:1. Okay, and if blood sugar level is less than 70 mg%, then insulin release is inhibited. Okay, and one more enzyme which is secreted from the beta cell is amylin, which is responsible for the motility of stomach motility, and entry of osmotic contents in the intestine. Okay, next we will see that causes of this type of diabetes mellitus. Okay, causes are, that is, first cause is autoimmunity. Immunity against the beta cells, which are common causes are HLA genes. Major histocompatibility is the common cause, and genes which are responsible are HLA, DQ1, HLA, DR2, HLA, DR3. Any one can be responsible for the autoimmunity of beta cells against the beta cells, or everyone can be responsible. Means HLA-DQ1 alone possible, HLA-DR2 alone possible, or HLA-DR3 alone possible for this type of cause, or they three can be possible for this type of cause. Next cause is our viral cause. Viral cause, that is the Coxsackie B virus, and then is our rubella virus, which cause fulminant diabetes. Why we say the name fulminant diabetes? Because symptoms start to develop in 8 to 12 weeks of infection. Okay, after infection. And next is our mumps virus is also responsible. And the most common cause from in viral cause is the Coxsackie B virus infection. Okay, due to these cause, in past some students studied, and some teacher also teach that type 1 is present in children and type 2 is present in adults or olders. Okay, but viral infection can occur in anyone, that may be in children, maybe in adults. That's why this is completely wrong. We can't take age as a criterion for dividing the types of these diabetes mellitus. Okay, next cause come is, that is iron toxicity, which leads to bronch diabetes. Symptoms are bronching or hyperpigmentation in skin, or cirrhosis, and the cause of diabetes development, that is the beta cell mass decrease. Why? Because of the iron toxicity, and beta cell mass decrease leads to insulinopenia. Okay, and next we will study the treatment of this diabetes. Treatment, that is, first of all we will count the carbohydrate person is taking, and according to it, first of all we will decrease some of the level of carbohydrate if he is taking more, and according to the level we will give proportion of insulin. Okay, so first of all carbohydrate counting, then give insulin proportional to it. Okay, then we will do insulin supplementation, which is if we are giving insulin, how we can supply insulin in the person. Most common route is subcutaneous. Okay, and how we can give subcutaneously insulin? By some methods that are insulin pump, next insulin pen, and more that we will study. First of all we see these types. In insulin pump, it is a device it is processor installed device which makes the insulin entry basal insulin like pancreas. Means this device work like a artificial pancreas, and it secretes the insulin uh, like normally basal insulin. We have one option here, that is the bolus insulin, which is secreted by this device 25 to 30 minutes before the diet intake, which time is set in this processor by us. It If a person takes a diet at 2, we set the time in this device, and before 25-30 minutes, like at 1:30 or 1:35, this processor start to secrete bolus insulin, and this is the best method. But as this use technology, so it is also expensive method, so some can't afford this method, so we deliver insulin by insulin pen, which is painless. It has minute small, very small pin which inject insulin. It is painless and bloodless delivery of insulin. Those who can't afford insulin pump, for them insulin pen is the best method. And next is our sites of insulin injection. In subcutaneous route, we will inject insulin on the anterior abdominal wall, 2 centimeter far from umbilicus, like if this is the anterior abdominal wall and here is our umbilicus, then we will make a 2 centimeter gap where we can give insulin, and we can give insulin in that area, in anterior abdominal wall. And next is arm, in the lateral side of the arm, and in the latero anterior surface of thigh, and buttocks. best method. And next is our inhaled insulin. And this includes Afrija and Exubera. Uh, Person can't take these, and I also not recommend to use this method, because by this method uh, accidents can also take place sometimes. Okay, then we have multi-dosal vial with 1 ml syringe. Now we will see the complications of insulin. That is, first one is Samogai effect or Samogai phenomena. It occurs due to overtake of insulin during bedtime, and in the and it can also occur due to less carbohydrate intake proportional to insulin intake. What happens in this phenomena? In this phenomena, during midnight, or like patient slept at 9 a.m., we will see in this graph, and at 4 a.m. hypoglycemia takes place. If person get up at this time, then person has tremors due to hypoglycemia, and due to hypoglycemia, rebound of glucose occurs in the morning by some hormones, which includes cortisol, growth hormone, and glucagon. Due to these hormone release due to hypoglycemia in early morning at 7 a.m., person have hyperglycemia. And in next we will see dawn phenomena, which says dawn phenomena or dawn fact. It occurs due to less or down insulin production, or due to less or down regulation of GLUT4, or increase insulin clearance from blood. What can it lead to? It lead to only hyperglycemia in the early morning. Like this, a person slept at 9 a.m. Slowly glucose level increase in the blood due to less insulin or less glucose intake by as GLUT4 down regulation takes place in the adipose tissue or muscle tissue. Which leads to hyperglycemia in the morning, in which these phenomena. Here we have Samogai effect, and here we have dawn phenomena. Samgai in Punjabi in India, Samgai means she slept with overdose of insulin. This is easy trick to remember. And down sounds like down regulation of GLUT4 or down insulin means less production of insulin. Okay, and in Samugai we have first hypoglycemia in the midnight, then due to rebound hyperglycemia takes place due to cortisol's growth hormone and glucagon. And in dawn phenomena we have only hyperglycemia in the early morning.